Hi everyone, just waiting for everybody to join.
I see a lot of familiar names outside of UK, Czech Republic,
Oh wow.
Canada.
See, the numbers are still going up. Okay, that looks good to me. Hi everyone, and welcome to our second supporter session of the year. Thank you so much for joining us this evening if you're in the UK or Europe. My name is Shajia, and I'm the Clinical Research Network Manager at Spinal Research, and today I'm going to be moderating the webinar. So to start with, I'd like to run through some quick housekeeping, only 2 points really. So firstly, we'd like to just let you know that this session is being recorded and we'll share it with you guys afterwards by uploading it on YouTube. And secondly, you're very welcome to submit questions using the Q&A function throughout the session. We encourage you to sort of submit those questions and we'll make every effort to answer as many as we can. So it's my pleasure to introduce you today to Dr. Andrei Krassioukov, otherwise known as Dr. K to some of his patients. He's a world-leading expert in spinal cord injury research and rehabilitation medicine. He's also the Professor of Medicine at the University of British Columbia and a clinician scientist at ICORD, otherwise known as International Collaboration on Repair Discoveries. He's an internationally recognized expert in the area of autonomic dysfunction following spinal cord injury, and today he's going to speak about his latest study, which is going to focus on an area that's consistently been identified as a priority by individuals with lived experience of spinal cord injury, and that is the loss of bladder, bowel, and sexual function. So I'll pass it over to Dr. Krassioukov.
Thank you, Sajja. Can I start?
Yeah.
Perfect. Good morning or good evening, which part of the world you are. Thank you very much for introduction. I saw that we are connected with a great deal of colleagues and friends from UK and across the Europe and Canada. Today, I will have a difficult task. There are three very important organs in our body, which we can talk about them for a long, long time, and I have only 30 minutes. That's why I will present a bird's eye view of experience in my laboratory, what neuromodulation can offer individuals with spinal cord injury in order to manage bladder, bowel, and sexual dysfunctions. First of all, I would like to acknowledge the support of numerous national and international organizations, research grants that presently underway in my laboratory. I also would like to acknowledge that I'm on advisory boards of numerous technological companies. What I will start with, I will start to present, first of all, concept of invisible disability after spinal cord injury. I discuss also with you what are the priorities that are identified by individuals with spinal cord injury, not by scientists. And you will hopefully see that sometimes it's a big difference between what person with spinal cord injury wants and scientists think they want. And finally, I've outlined you what are the advances we made during the last probably 5-10 years with respect to use spinal cord stimulation in order to positively impact bowel, bladder, sexual dysfunctions in people with spinal cord injury. I will start with this image. If you look at this image, what will be first things in your mind? What this person who is quietly sitting on a wheelchair and everybody walking and running about him, what is the priority of these individuals in the recovery after this devastating injury? And I hope you probably know that majority scientists for many, many years focused on aspects of cure paralysis. Yes, it is a devastating issue after spinal cord injury. But what we learn actually when we ask people with spinal cord injury, and this data published by Dr. Kim Anderson, who by herself is a person with spinal cord injury experience and a scientist, she asked more than 600 individuals in the United States what you would like to recover first. And what you can see here in the green, people with paraplegia, Number one priority was sexual dysfunctions. Number two, bladder bowel dysfunctions. People with high level of injury clearly stated number two, I would like to have my sexual functions back. Bowel bladder were number four. And interestingly, what I mentioned to you that scientists and clinicians for many years focus on paralysis, ability to walk, movement was number 4, 5 priorities among people with spinal cord injury. And this was one of the, I believe, eye-opening study for many, many clinicians and scientists that realized, we probably have to talk more often and more serious with people with spinal cord injury who we're trying to help actually. Why it is taboo to talk about how we're pooping? This is a question which I would like to ask you. And when's the last time you talk with somebody or with your family member? How are you pooping? How are you going to bathroom? People who have children or grandchildren knows how crucial and how happy grandparents and parents see when child poop without any problems and everything is fine. We can learn a lot about how a child is pooping from their expression, how happy they are after this very important issue. And interestingly, Google Science telling us couples who talking on a regular basis how pooping, how they are comfortable in toilet, they are more happy couple. That's why today we will start talking first of all about pooping. But before I will go to talk about more bowel bladder dysfunctions, I would like briefly to introduce you how complex neurological control of this pelvic organ function is. First of all, we have two autonomic components of the nervous system. It is a sympathetic and parasympathetic nervous system, and they are involuntary. We cannot control them by our mind. They're doing all what's happening in our body by themselves. But we also have voluntary control of our pelvic organs, bladder, bowel, and sexual functions. And this is a somatic nervous system. How we, for example, can relax the anal sphincter or bladder sphincter, or when we talk thinking about something pleasurable, we will have sexual arousal. That's a combination of these three systems allow us to function normally with respect to bowel, bladder, and sexual dysfunctions. Unfortunately, when spinal cord injury occurs, and it can happen at different levels, variety of dysfunctions will happen with the bladder. For example, there is an overactive bladder. Bladder sometimes start to contract totally unregulated and unpredictably. Therefore, people with spinal cord injury will develop incontinence, for example. There is possibility of developing of bladder stone, increase developing in bladder cancer due to use of catheters, and then, of course, frequent urinary tract infections. With respect to bowel dysfunctions, depending again on the level of injury, we can identify upper bowel motor neuronal injury or low bowel motor neuronal injury, and their presentation will be slightly different. But most important, after spinal cord injury, our gut becomes lazy, very slow. Therefore, people with spinal cord injury predisposed to constipation. And then, of course, fecal incontinence can happen because anal canal cannot hold our fecal masses inside of the rectum. With respect to sexual dysfunctions, in men, we will have erectile dysfunction, ejaculation dysfunctions. Both in males, females present with orgasmic dysfunctions. They cannot reach this peak of pleasurable sensation. And then, of course, in women, we will notice decrease of vaginal lubrication, which also prevent to enjoy sexual activities. That's why, again, this is only a glimpse on the variety of abnormalities that we will see with respect to these three pelvic systems. What is neuromodulation? Neuromodulation defined as a possibility to alter nervous system activity through the targeted stimulation. And this stimulation could be either electrical, and I will talk about today about electrical stimulation, or chemical, pharmacological. And this will allow modulate either lost or altered nervous functions which are retargeting. What is neuromodulation actually can offer to people with spinal cord injury? And I asked this question long time ago. And first of all, we have to realize that there are two major possibilities how we can activate spinal cord. We either can perform surgery and implant electrical electrodes, electrical stimulation inside of the spinal canal above the spinal cord, and we call it epidural spinal cord stimulation. Or we can use non-invasive or transcutaneous spinal cord stimulation, when we can just put glue electrodes above the spinal column at the different levels and activate the different structures through the non-invasive spinal cord stimulation. Interestingly, this is not a totally novel methodology. For the first time, FDA approved spinal cord stimulation in 1989 for the use of management of intractable chronic pain. And some of the patients with spinal cord injury actually underwent these procedures before. But during the last 10 years, we totally changed our understanding what actually spinal cord stimulation can offer to people with spinal cord injury. At the present time, this is a clinical trials in my laboratory, either already completed or still in progress. And today, predominantly, I will focus with data from Spinal Research Trust grant, which I received in my laboratory, but I also acknowledge numerous other clinical trials, either completed or in progress in my laboratory. Probably some of you are aware that my laboratory and my long-term interest in spinal cord injury was about cardiovascular dysfunctions. What's happening after in people with spinal cord injury? Why blood pressure sometimes go up, sometimes go down, which are dramatically interfere with activities such as participating in a sport or participating in sexual activities. That's why one of my first questions in laboratory, can we help the person with spinal cord injury to improve blood pressure control? And one of the devastating conditions which people with spinal cord injury experiencing is very low arterial blood pressure, also known as orthostatic hypotension. When person with spinal cord injury trying to stand up or sit up, blood pressure going extremely low. And this sometimes results even in syncope, loss of consciousness. There's numerous years ago, in a collaboration, of course, with my students, some of them already at the present time independent scientists, we look on one subject in my laboratory. He was from my clinical practice, who went to Thailand and received epidural stimulator in Bangkok. He come back home, and what we try to look how he respond, his blood pressure respond from the changing from supine position to vertical position. It's called tilt table assessment. And what you can see on the next slide, if you look on the yellow line, first diagram, it is changes in his systolic blood pressure. It dropped dramatically when it was transferred from the supine to the vertical position. And then his cerebral blood flow in middle cerebral artery, which is crucial for our brain function, is also dropped dramatically. However, when we put him in the tilt table up position with spinal cord stimulation, we were able to totally normalize his systolic blood pressure. There was no drop blue line, and his cerebral blood flow also continued to be normal. He also functioning better. His cognitive function is improved. This was one of the first paper published with respect to benefits of spinal cord stimulation. This is again implantable stimulation for blood pressure control in person with spinal cord injury. But of course, we ask questions. Can other autonomic functions can be improved? And we look and focus on bowel function. And in collaboration with my former postdoctoral fellow, Dr. Matthias Walter from Switzerland, he's right now a urologist, we conducted a study with one of the subjects who also underwent transcutaneous epidural stimulation. And what we learned, as probably majority of people with spinal cord injury know, is that timing needed to evacuate bowel is extremely long. And before the stimulation, without stimulation, it took him approximately 60 minutes to evacuate fecal masses from the rectum on the toilet. However, when we found different electrical parameters for epidural stimulation, it decreased by 50%. Can you imagine you spend less than half an hour on a toilet instead of hours or 2 hours as some of the patients will spend? Interestingly is that our data were repeated by other investigators around the world, and you see numerous publications came later using either epidural or transcutaneous implantation. But we also wanted to know how it's happening, why people improve their timing to evacuate the blood, and what we did, Bowel, and what we did in our grant, actually supported by SRT, we look into the anorectal pressure with special probe inserted into the rectum of person with spinal cord injury. What you see on this movie, you will see that colors of this diagram will change either from yellow to red, and red, more red color indicated increase in the pressure. You see we're starting with stimulation off, there is mostly yellow colors present. Right now we're gradually increasing amplitude of stimulation of spinal cord. This is a transcutaneous stimulation, and you will see that with increase of amplitude, intrarectal, intraanal pressure is increased. And this what will help person to evacuate quicker bowel and as well to hold anal tone and prevent for bowel leakage. That's why this is one of the very interesting insight into the mechanisms, how spinal cord stimulation is actually working. And you can see the data from the one of the two patients who underwent the stimulation that we dramatically increase intrarectal pressure during the spinal cord stimulation. But we also want to know total transient time with respect to constipation. And we conducted very interesting, very simple in a way, test. It's called blue poop transient time. What will happen, person has to drink or eat agent, with colored agent, it could be either blue, and then we're waiting when this color will occur in the stool. We conducted a quite interesting study. First of all, every single members of my laboratory, individuals without spinal cord injury, conducted this test on themselves. And as you can see here, average time of total bowel transit time was approximately 34 hours, but it could range between 10 to 70. And then this is a totally new data. This is a just recently analyzed data by one of my undergraduate students. At baseline, people with spinal cord injury without spinal cord stimulation, their total bowel transit time was 65 hours, quite prolonged. At the end of the clinical trial with the transcutaneous stimulations that I described you, supported by SRT, their total transit time decreased to 45 hours. Unfortunately, after follow-up for 8 weeks, when already the patient was out of the trial, unfortunately, this time again increased to 85 hours. That's why definitely we demonstrated that spinal cord stimulation can improve colorectal functioning and transition of the fecal masses and food through the gut, which is one of the hopefully help to prevent constipation in these individuals. Our next question was, can we actually improve sexual functions in people with spinal cord injury using spinal cord stimulation? This data is actually from the clinical trials that conducted in collaboration with Dr. Darrow with University of Minnesota. This trial called eSTEND. This is a epidural implantation trial. We examined 15 individuals who underwent spinal cord stimulation for more than a year. There were 10 males and 5 females. Because females are rarely examined in the spinal cord injury research, we focused initially our data on female sexual function. And what we found is that impact on female sexual distress score decreased dramatically with the regular use of epidural stimulation. And more exciting, that orgasmic sensation improved dramatically. One of the first patients, she was actually a Canadian patient enrolled in this trial. She reported that after a few months of epidural stimulation, for the first time, after 8 years, she was able to experience orgasmic sensation. And again, I would like to remind these individuals with motor sensory complete spinal cord injury. Our data on sexual function from my SRT trial is still under the analysis. Next question I will ask, do you know how high your blood pressure will go up when you're going to poop or to pee? Do you ever measure blood pressure? I would like, of course, to know how many patients ever measure their blood pressure when they're going to toilet. And what interestingly is that this data were collected, first of all, in able-bodied individuals by scientists in India. Typically, in able-bodied individuals, when we're sitting on a toilet or squatting on a toilet, blood pressure increased slightly by about 8 to 7 millimeters of mercury, but it's still a significant increase. People with hypertension will also increase blood pressure up to 15 millimeters of mercury. But what is crucial from the clinical point, unfortunately, up to 40% of people, able-bodied individuals, could develop stroke during the defecation because we're trying sometimes push our fecal masses out. So this is able-bodied individuals. What we do know about spinal cord injured individuals? As you know, many people with spinal cord injury need help with evacuation of bowel. And we either recommend them to use digital rectal stimulation, it activates reflexes within the colon, or use anal irrigation. And I hope many listeners of today's talk using these procedures. And what we found when we collaborated with Dr. Klaus Krog in Denmark, if person doing transanal irrigation, blood pressure increased slightly up to 20 millimeters of mercury. With the digital rectal stimulation, blood pressure increased up to 50 millimeters of mercury, which is obvious response related to autonomic dysreflexia. And finally, bladder feeling, also pelvic organ, when we distended it, also could respond with autonomic dysreflexia. That's why in people with spinal cord injury, we have to be aware dramatic changes in arterial blood pressure with a bowel function required to perform. And of course, we don't want to see this situation. This is actually a case reported by colleagues from Spain, when an individual with spinal cord injury in a chronic stage, well rehabilitated, developed urinary tract infections, which is irritation of the bladder, and resulted in stroke. We want to prevent this situation. And therefore, in collaboration with my two students, one of the Dr. Sachdeva, who is right now assistant professor in Lexington, Kentucky, and Dr. Tom Nightingale, my former postdoc, who is right now lecturer in Birmingham. He's back to UK. We conducted a study looking how we can prevent autonomic dysreflexia due to digital rectal stimulation with spinal cord stimulation. What you see in the first diagram, this is increase in systolic and diastolic blood pressure during digital rectal stimulation, which was performed by me. Blood pressure increased by 40 millimeters of mercury in this patient. When we applied spinal cord stimulation in lumbar sacral region, we were able to totally eliminate this increase in blood pressure and eliminate autonomic dysreflexia. You see the data on a third portion of the slide, and we repeat it on numerous times. This data already published. So this is another very interesting aspect of possibilities of spinal cord stimulation to improve blood pressure changes related to bowel and bladder activation. Finally, obviously, some of you probably interested, what about motor function recovery after spinal cord injury and spinal cord stimulation? This is not a novel data. We already, some laboratories previously showed that spinal cord stimulation could improve motor functions. However, with respect of today's talk, all my clinical trials in my laboratory focused on autonomic recovery. We did not expect that we will activate or find parameters that will improve motor function in our participant. But what exciting, what we found, that this is what I will show you. One of the subjects participated in ISRT trial. He's 28 years old gentleman with C4 motor complete sensory incomplete spinal cord injury 11 years after injury. He had no motor function below the level of injury. You hear right now voice of one of my former postdoctoral fellow, Dr. Samajima. He is right now assistant professor in Washington State University. And you will see first, he asking this subject to move his lower extremities without spinal cord stimulation.
Without stimulation, right leg up, 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 and relax. And left leg up, 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 relax.
You see no movement. However, with the stimulation,
and with stimulation, right leg up, 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 and down. Good. Left leg up, and down, and right leg up again.
Again, I hope it's evident for you. This is not a spasm. This is a voluntary control movement in person with a chronic spinal cord injury who underwent stimulation actually for improving bowel and bladder function. But simultaneously, we were able to see motor positive response. And what's exciting that this individual with motor complete injury was converted immediately to AISC, motor sensory incomplete spinal cord injury. So as these components of the study, we notice in numerous of our subjects, but not all. This study right now led by, again, my postdoctoral fellow, Dr. Raza, and he is right now investigated what are possible predictor factors that person with complete chronic spinal cord injury could recover motor function as well as autonomic functions. I would like to finish my presentation with possible explanation what we believe how spinal cord stimulation can actually work through the various mechanisms within our central nervous system. By applying spinal cord stimulation either epidurally or peripherally on the skin, we're activating sensory fibers, what we call them primary afferents, that will bring information to the spinal cord. Inside of the spinal cord, this electrical activity will activate interneurons, which will spread their responses to various neurons, autonomic as well as motor. With respect of motor, first of all, it will be activated sympathetic preganglionic neurons, which are responsible for the bowel, bladder, sexual, blood pressure responses. And finally, of course, target organ will respond. Either gut contraction occur or blood vessel contraction will occur when spinal cord stimulation will come to the target organ. And this is a paper already published by my students. And I would like to thank you all for attention, and I will be happy to answer questions. Thank you very much.
That's great. Thank you so much. I can already see that we've got some questions coming in. Please do keep sending them through, but for now, I'll start with a question that's been sent through by Tony, who asks, is there any data on the effects on male sexual function?
Absolutely. Yes, we do have some interesting effects. It is in progress. What we know from the reports, that's how we're assessing male sexual function responses. So there are validated questionnaires, but we also, my colleague, Dr. Stacy Elliott, who is the director of Sexual Health Clinic in Vancouver, conduct also a structured interview asking a variety of questions. What first we noticed that our participants responded that their erections occurring more quickly, more easily, and it's prolonged. And then one of the participants, his spouse, came to me and hugged me and said, Dr. K, after 8 years, I had a first time sexual intimate contact with my husband without any help. That's why I cried, she cried, but we're still under the analysis of this data. It's coming soon for publication.
Oh, that's great. Thank you. We've also got a question from Claire Guy, who's a physiotherapist in the UK. Claire asks, is the stimulation invasive or non-invasive? And she also asks, can the same stimulation parameters be used for all areas? So bowel, bladder, sexual function, or would the parameters have to change?
Very good question. So first of all, as I described to you, there are two possibilities. We can implant electrodes, and there are few companies which produce right now these electrodes. It is invasive, requires surgical procedure, quite expensive. But we also have capacity right now to utilize non-invasive spinal cord stimulation. Physical therapists will be very familiar with this transcutaneous spinal cord stimulation, which is used forever in our clinical practice. With this, but again, difference in the devices could result in difference in responses. In order to activate spinal cord, we really have to push with a high intensity, but also different frequencies, different modalities. What we see right now is the right difference in the modalities that activate motor sensory function versus autonomic functions. I believe what we see from our results, there is a possibility we need to tune some stimulation parameters to activate and to receive response from the bowel and some responses from sex. That's why it's quite complicated. It's not so easy. Plus, don't forget, when we implant electrodes, we're putting the electrodes typically in one place. We cannot easily move it up and down. With the transcutaneous stimulation, we found that some areas of spinal cord respond better for bowel, some respond better for blood pressure controls. That's a position of electrodes also could change effects of spinal cord stimulation. But some of this data are coming already from publication, and actually my laboratory led initiative. Every single scientist and clinician who publishing in this area have to report parameters, frequency, intensity, and localization of electrode that we can understand eventually what is working and what is not.
Great, thank you. We've got two very similar questions, one from Manu and one from Julie, who asks, would this work if someone has been injured for 40 plus years?
Again, as you know, probably for many years, we believe that most recovery will occur within 6 months. And by the end of the year, this is what typically we talk about maximum recovery. The rest, we never saw typical recovery of additional motor function or any other functions if we not use some kind of pharmacological excitation or neuromodulation, or right now, spinal cord stimulation. As I showed you one of the examples, this young gentleman was 11 years after spinal cord injury when for the first time he was able to voluntarily control his lower extremity. That's why, and many other laboratories demonstrated that even a chronic subject, 40 years could be possibly, we can see some motor recovery as well as recovery of autonomic functions.
Thank you. And we've got two questions from Brian. One is, are you seeing any patterns depending on the age of the patients? And the second is, has consideration been given to those with catheterization and stomas?
Very good questions. That's at the present time, because we're in a clinical trial stage, inclusion and exclusion criteria are very clear. That's for example, with catheters, unfortunately, for reasons that we can do best urodynamic assessment in the individuals who are using self-catheterization, where bladder compliance still preserved in comparison with a long-term Foley catheter. All patients who I'm studying right now have intermittent catheterization. Age, our age limit in a majority of clinical trials 65. Some clinical trials were 70. That's why we do see responses even in 70 years old individuals with a chronic spinal cord injury. This is actually clinical trial results already published by Anwar on improvement of hand function. That's why my oldest patients participated in clinical trial was 70.
Thank you. And we've got Steve who's asked, what is your prediction for commercially available products to help with these functions? So how soon could they be available?
Very good question. So we do know that, for example, Medtronic and Abbott already have commercially available implantable spinal cord stimulators for spinal cord stimulation. This is already commercially available. There is a very hard-working team of group Onward, which are working on new electrodes and new implantable stimulators for implantation. And there are, I believe, right now 5 to 6 companies which are working on non-invasive stimulation. I showed you one of the companies with which I'm working at the present time is Spinal. They just completed their first pivotal clinical trial looking on use of this device on bladder function, and I'm looking forward to see results. And then next step will be for application for FDA for approval in clinical use. However, there is already available one of the device by Onward. They completed successful pivotal trial for hand function improvement, and FDA approved this device just last December. So far as this is my knowledge, what major 2 companies which are very close, either already approved for FDA or waiting for, will apply for FDA approval.
Thank you. And Jenny has asked, do the improvements remain after the stimulation is turned off?
This is a very, very difficult question. That looks like, based on the data from my lab and from other lab, some function could remain improved. Unfortunately, motor function we see immediately deteriorate if you don't stimulate spinal cord. You need continuous addition stimulation in order to see motor recovery. What I showed you with bowel function, as soon as we stop bowel stimulation, unfortunately, bowel function returned to the pre-stimulation pattern. That looks like we need additional stimulation for long term in order to maintain function of recovery.
And we've got some questions coming in about injury completeness. Helene asks, will this work for a complete Asia A injury?
Yes, it will. That's why all my subjects in my laboratory, we're focusing on motor complete spinal cord injury, AIS-A, and also on motor complete AIS-B. It will work. But again, we still don't know what is required for subject with AIS-A to be responder. We're still trying to investigate.
Thank you. We've got loads of questions coming in. We've got over 70 questions. Thank you so much, Dr. Krassioukov, for taking them. I'm trying to kind of go through them as best as I can. We have got another question from Eugene, who asks, what will it take for more of this technology to become available? All of this stuff sounds amazing, but it feels like so few of us can access this technology.
You absolutely, person who is asking question is absolutely correct. This is my question to industry with whom I'm collaborating and working. My first question was to industry and people who are developing these devices. What will be price? What will be affordability? At the present time, I believe that presently first approved FDA approval device by Onward is $30,000 US. It's already available. But I hope with the more companies coming to the competition, this price will go down. And definitely, I totally agree again with the person who asked the question. It is still research-based devices, and we're still at the beginning of exploring these possibilities.
Thank you. Andrea says, great presentation. What will you advise between epidural or transcutaneous stimulation?
I believe as a physician, as a scientist, I can explain to my participant what is advantages, what disadvantages. Choice will be yours. And okay, advantages, disadvantages, for example, with epidural stimulation, advantages, it can provide very precise, low intensity stimulation on specific areas of spinal cord. It's more precise stimulation. However, you have to go through the surgery. And unfortunately, surgical implantation, it's not a cheap issue. With transcutaneous stimulation, no surgery, you can move electrodes up and down, big advantage. You can stimulate. Today you need blood pressure, you put electrodes a little bit up. Right now you need to poop very quickly, you put electrodes a little bit down. And that's why this is a flexibility which is offering transcutaneous. That's why by the end of the day, I believe each individual with spinal cord injury have to make personal decision.
Thank you. And Amanda asks, is there any data on the combination of neuromodulation and cell therapy?
Not to my knowledge on data published. However, I do know that clinic in Thailand is offering patients who coming as a tourist for medical tourism, and they offering them combination of cell transplant, which I don't know which they implanted, and implantation of spinal cord stimulation. And unfortunately, this clinic implanted many patients with spinal cord injury, including in my practice, but I didn't see yet any published data.
Thank you. And Steve asks, what's now next with this research, with your research?
This is my slide, which I excluded from starting from presentation. That's one of the, I believe, tasks for clinicians and scientists in this area. Definitely find and precisely tuned parameters, which question was asked before, parameters that will activate one organ or another organ. This is absolutely right now needed to be studied. I believe we definitely have to compare benefits between the implantable devices and non-implantable devices. Do they produce the same effects? So far, we see looks like we can produce practically the same effects with respect of motor and some bladder functions. Another issues which has to be examined, cost effectiveness, because it will be big investment either from the family of person with spinal cord injury or society to make decisions that each person with spinal cord injury have to receive implant or have a home personal device, which at the present time is quite expensive and not everybody will be able to afford it. That's why affordability of this therapy will be another big issue.
Cool. And slightly different question here. We've got Anna asking, do you have any plans to conduct studies with people with spinal cord injuries due to non-traumatic causes? And do you think it could work in the same way for them?
Very good questions. That's why, yes, ideally, yes. We have to just find agency which will fund this. But I can tell you that at the present time, I do have already established collaboration with numerous centers in China to study effects of implantable or non-implantable devices on use in multiple system atrophy and Parkinson's disease to manage low arterial blood pressure and also other autonomic dysfunctions which are commonly present in these neurodegenerative disorders. That's why it looks like we do know that other neurodegenerative disorders could be also effective with the use of these technologies. That's it is possibility. One of the aspects I would like to add about future plans. With novel technology coming to the use, it's a great need of education of medical doctors, physical therapists, occupational therapists, how to utilize this technology. Because this is right now some kind of totally new directions. It's not yet in the scope of practices in physiatrists or occupational therapists and physical therapists to apply spinal cord stimulation to improve bladder, bowel, or motor function. So this is another big aspect that either with support of industry or changing in the license practice guidelines has to be added for the future.
Thank you. And Supti asks, is there any difference between patients who started early versus started late with the transcutaneous stim?
We don't have this data. I know that there is a few clinical trials upcoming with early implantation We actually just started new clinical trials with support of Department of Defense in Ukraine, where we're starting in subacute stage of spinal cord injury within the first 6 months, in comparison what I'm running right now in Canada, when it's majority of my patients are chronic. So that's why it's still under investigation. Possibility, maybe we will get more recovery, maybe.
Okay. Tamsin says, thank you for sharing your findings. Excellent talk. Could you share any adverse effects that you encountered? And if so, how you overcame them, such as the impact on spasticity?
Absolutely. Very good question. Yes, there are possible adverse effects. That's why from non-implantable, there is a possibility of small burns under the electrodes because skin sensitivity in each person is different. That's why from more than 6,000 procedures that conducted in my laboratory, we probably saw 3 to 5 procedures when we get some small burns from the electrodes. It's manageable. That's why we're very, very attentive how we put electrodes, how we change electrodes, and then check skin condition before and after every single procedure. This is one of the possibilities. Second aspect, it's an unpredictable blood pressure increase due to autonomic dysreflexia. As I mentioned to you, we can increase blood pressure with spinal cord stimulation in order to improve low blood pressure. But if it's go too high, that's why we recommend always to measure blood pressure during spinal cord stimulation in order to prevent episodes of autonomic dysreflexia. Because by just decreasing intensity of stimulation, you will drop arterial blood pressure to what desired level you want. That's why skin burns and adverse effects with respect of blood pressure. Another aspect which was reported just recently at the American Spinal Injury Association in Phoenix, colleagues from a Mayo Clinic during urodynamics procedure and spinal cord stimulation noticed significant reflux. It is urine went back to the kidney, and this is what we don't want to occur because the sphincter is closed, blood starts to contract, and urine going back to the kidneys, which is called backward reflex. We don't want to occur this, and this was reported by colleagues from US. This is, I believe, my major will be concerns with transcutaneous. With epidural, these procedures are already well established. For many, many years, patients were implanted for pain management. There are previously reported some malfunctioning electrodes, and then longevity of the actually stimulators, which will require to replace. And this is one of the, it's not complication, but inconvenience that patient has to go to do another surgery when stimulator batteries fail and need another battery exchange.
Thank you very much. I'm conscious we've racked your brain. We've already answered 15 questions and we seem to be getting more and more. But for now, I think
I'm happy that audience so tuned and so interested. Absolutely.
definitely very engaged. So thank you everybody for asking all your questions. We'll ask one final question now for Dr. K, and that is, will spinal stimulation work on lower motor neuron injuries?
This is a challenging question. So far, I know that in my clinical trials, we unfortunately excluded patients with low motor neuronal injury. The only things what I can say is that we do know that even with low motor neuronal injury, some neurons partially preserved, low motor neurons. Some neurons obviously were injured and totally dead. That's why we have to try. We have to do study to answer this question. Good question. Challenging.
Okay, so thank you so much, Dr. Krassioukov, for taking the time out to present to us today. And thank you, everybody who has put a question in the chat. Now, I do realise there are many, many more questions open than we've managed to answer today. Clearly, it's been a really popular talk, and we're so pleased with the turnout. What we are going to do is make every effort to collate all the unanswered questions and get back to you via email or whatever method we can. So thank you again. It's not been wasted. We will make every effort to get back to you guys for all the questions that remain outstanding. But that's everything from me. Like I said already, thank you again so much to Dr. Krassioukov for his time, for presenting and for answering all those questions so early in the morning.
Sandra, may I just finish with one statement? For
Sure.
every single individual with spinal cord injury who interested in spinal cord stimulation or any other research, ask questions, go to experts, find what people with experience with spinal cord injury who underwent already stimulation feel about one or another. That's why talk and ask questions. Don't hesitate. All the best. It was a pleasure to talk with you all.
Thank you. Thank you again so much. And thanks everybody for joining us today. If you've got any questions, you can send them to our email on info@spinal-research.org, and we'll do our best to answer them. I have also collected all the outstanding questions in the chat box, so we will do our best to get back to you. Thank you again, everyone.
Bye-bye.
Bye. Take care.